Okay, nice to see the room almost half full, I would say. Or I guess I'm exaggerating, a third full. Good morning, everybody. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. It's always really special to have one of our named lecturers, and today I am delighted to ask Dr. Stephen Cates, who is our Section Chief and Division Director for Rheumatology, to introduce our named speaker series today in the speaker. Thanks.
Thank you. So it is my pleasure to introduce this morning's Percy Russell Lecturer. Dr. Hani El-Gabalawy is a professor of medicine and immunology at the University of Manitoba and a senior clinician scientist at the Arthritis Center and the Manitoba Center for Proteomics and Systems Biology. He's held their endowed rheumatology research chair since its establishment in 2003. From 1997 to 2000, he was a visiting scientist at the National Institute of Musculoskeletal Health and Arthritis in Bethesda, Maryland. And from 2013 to 2017, he served as the scientific director of the CIHR Institute for Musculoskeletal Health and Arthritis. Dr. El-Gabalawy's research interests have centered around the pathogenesis of rheumatoid arthritis and the mechanisms that initiate and sustain this prevalent autoimmune disease. To address translational research questions in this area, he and his colleagues established a unique cohort of Indigenous North Americans who are at increased risk for future RA development based on having a strong family history of autoimmunity. This large cohort has been followed systematically for almost 20 years, with individuals who developed RA compared to those who did not. And I would mention that I think it was my very first research project many years ago that I participated in medicine. It was probably one of the first projects from this study. Ongoing studies have revealed important insights into the origins of RA autoimmunity, the mechanisms by which autoimmunity matures and become pathological, ultimately resulting in the onset of chronic joint and systemic inflammation. Dr. El-Gabalawy is a national, international superstar of rheumatology who honors us this year as this year's Percy Russell Lecturer, named in honor of Drs. John Percy and Dr. Anthony Russell, rheumatology superstars in their own right, who established our division of rheumatology in 1968. Dr. El-Gabalawy's topic this morning is Undertaking Prediction and Prevention of Rheumatoid Arthritis in First Nations, which is particularly relevant to our local group this year, as we've recently assumed care in Edmonton of well over 400 patients from the Northwest Territories. Without further ado, Dr. El-Gabalawy.
Thanks very much, Stephen. And I have to say that yesterday, Stephen saved me from WestJet after they messed up my travel plans. So thank you. I'm not going to go into the story in any kind of detail. So wonderful to be here. Wonderful to be here for this lectureship, and especially with Tony Russell sitting there. And Tony and I go back a long way, and Walter and colleagues that I've known for a long time. So we're going to talk about the work that we've done in predicting and ultimately trying to prevent rheumatoid arthritis from starting in quite an at-risk population, and I'll show you some of the data to support that. I'm hoping there's no Mac PC issues here, but let's just. Good. Yeah. Okay, there we go. We got it all. So we're going to do 4 related things here. Summarize the gene-environment interactions that predispose some, but not all, First Nations to rheumatoid arthritis. Describe the features and outcomes of RA in First Nations people. Outline how we've worked with First Nations communities to move this study ahead. And then summarize basically what we've learned so far and where we hope to go with this. So this is probably the most famous rheumatoid arthritis patient that we've known in the last 200-300 years, and that's Pierre-Auguste Renoir. And you can see pictures of him on your left side there with very typical rheumatoid deformities in the hand and, legendary kind of approach to painting. There's some pictures of him with a paintbrush in his teeth actually doing that. But that's the hands and the person that produced those incredibly treasured pieces of work. And it's a triumph of the human spirit over a chronic disease that just destroys people. Obviously, we're doing a lot better these days with preventing all of that, but and we'll come back to this the time of this picture and the identification of an individual with it. So there was back in the late 80s. Bruce Rothschild proposed a very interesting hypothesis. He says, okay, spondyloarthropathies, osteoarthritis, gout, these were identifiable in anthropologic remains from centuries ago, millennia. And there's no evidence in the old world of rheumatoid arthritis before 1785. And he looked at some skeletal remains from Alabama and Tennessee that have been, and they had evidence of what now we would call, this is fairly typical, bone damage from rheumatoid arthritis. Here you can see some radiographs of that, and you can see the actual remains themselves. And so he has posed the question, did Europeans bring something back from the New World to the Old World that got this whole ball rolling in the old world? And I'm just going to tantalize you with that because we don't have answers about that. Was it a transmissible agent, infectious agent, tobacco? I mean, there's just a number of environmental factors that, but you look back at, the ancient Egyptian remains and so on, there's no evidence of RA as it was detected in these First Nations remains. Okay, so this is a figure going over the natural history as we think about it now. On your far left, there's initial break in immune tolerance related to a lot of mucosal factors. We'll talk about that in a moment. That initial autoimmunity gets matured through a number of processes, which we'll also explore. At some point, the autoimmunity gets targeted to the joints. Okay, and that's an interesting phase and step, and we talked a lot last night about that, about how the synovium becomes engaged in this systemic autoimmunity and ultimately the development of chronic inflammation in the joints. So this stage of preclinical stage of breaking immune tolerance is dependent on some gene-environment interactions. And this is now an old slide, but not a great deal has happened. A few more SNPs have been added, a few more associations, a paper published in Nature by Okada a few years later, total probably of 100 or so associations, all quite strong, big p-values. But what I want to point out here is the contribution all of these genetic associations make are small compared to what the MHC contribution is. This is a disease that's driven by HLA genetics, and we'll explore that in a moment. The other thing I want to point out is the amount of variance in rheumatoid arthritis that's explained by the genetics is actually quite small. Where is that missing inheritance? And there's been a lot of work going to regulatory regions of the genome that are involved in this, as opposed to just encoding parts of the genome, as you see in this figure. Okay, so in terms of the major association, the HLA-DRB1, that's antigens get presented to the immune system, to T cells through that. And this is the reigning hypothesis that we have, which is called the shared epitope hypothesis. The rheumatologists have been familiar with this for decades, but it really explains a lot of the population associations we see around the world. And it goes like this. circled in red there is a sequence of amino acids in the side wall of this antigen-presenting molecule, and it's positively charged. And there are peptides that can fit into that and peptides that can't fit into that. And if you have an arginine-containing peptide, it's spit out, basically. It's not accommodated by this HLA molecule because of positive versus positive charge. But if you get a post-translational modification of that arginine, you get rid of the amino group and it goes from a positively charged amino acid to a neutral to acidic. It's accommodated much better by this molecule and presented to the T cell to activate it and so on. So that's been our guiding light so far in terms of the HLA genetics of RA. So if you look at that sequence in several predisposing HLA alleles, some of them Caucasian, the 405, for instance, is seen in Japanese populations, 401 is seen in Caucasians, as with 404. We became interested in this one, 1402, which is unique to indigenous North American populations. And it has the same predisposing sequence. You get the arginines, particularly in position 71 and 72. Now, the interesting thing is that this is incredibly prevalent in First Nations people. And you can see it's not just prevalent in patients with RA who are First Nations, but the background populations. You look at the Pima, the Tlingit, the Chippewa, in the Pima, for instance, more than 80% of the background population has this HLA allele. I mean, it's staggering. And so why is that the case? Did it afford some survival advantage? So it probably wasn't there to predispose people to RA. It probably afforded some kind of survival advantage. And this goes back to the Renoir theme that I mentioned earlier, with the massive influx of microbial organisms that came to the Americas from Europe. Did this help First Nations survive smallpox, TB, measles, all of this, the curses that affected the Americas? So if you're interested in reading a lot of really interesting hypotheses about this, Jared Diamond's Guns, Germs, and Steel is a fabulous book, one of the best I've ever read. Okay, so we couldn't untangle that. It was just we didn't have the tools to do that with. But what we did do is we took 1402 and had a nice 3-continent collaboration with a group in Brisbane, Ranjini Thomas and Jamie Rossjohn, and a group in the Netherlands with Renee Tuss and Uli Scherer and others, and groups in North America. And the crystal structure of 1402 was resolved, and we found some very interesting observations when we did that. As compared to other HLA alleles, what I showed you, they just don't accommodate arginine peptides. This allele accommodates both arginine and the citrulline peptide equally well, but if it's an arginine amino acid, it buries it in the peptide binding groove. If it's citrulline, it orients it towards the T cell. And you can see here two identical peptides, one with arginine, one with citrulline. The citrulline is presented to the T cell, the arginine is buried. So it's unique, and there's no preference for arginine versus citrulline as opposed to the other variants of the SHIRDEP. Is it associated with anti-citrullinated protein antibodies? The answer is unequivocally yes. We showed that. Is it associated with RA? And the answer to that is unequivocally yes. So I'm not going to cover any more genetics, and we've done a fair amount more about that if you're interested in reading more about some of the genetics of RA in First Nations. So let's turn our attention to the environment. And this is a nice summary of the environmental factors that we think contribute. And there's Dr. Jan Willem is a world expert in this area. here and Trevor. So if there's any tough questions, ask him, not me. So smoking by far is in most populations is the biggest environmental risk factor. And we're going to come back to omega-3 fatty acids and the age of menarche. But this is just kind of a nice summary of things. Some things are stronger in the literature than others as being established environmental factors. And there's a mucosal hypothesis that RA basically starts in mucosal membranes, whether they be in the gut or the lungs, exposure to tobacco, changes in the microbiome of the gut, or what we were interested in is periodontal disease changes in the oral cavity. I'm just going to show one slide about smoking because this is unequivocal now. It's from the Nurses' Health Study and just shows you kind of a dose effect of smoking and risk of RA. And this has been replicated in multiple populations. And unfortunately, the population that we deal with, First Nations people, smoking rates are quite high. So enough said. Now, periodontal disease, why is that interesting and what does it have to do with RA? There's similar HLA-DRB1 risk factors that I just went over with you. It's chronic inflammation adjacent to calcified tissue in the teeth versus the joint. Similar, we talked a lot about matrix metalloproteinases last night and the role that they potentially play in damage to calcified tissue. An organism called Porphyromonas gingivalis, which the dentists and the oral biologists are very familiar with, common cause of periodontal disease, has its own PAD enzyme, which converts arginine to citrulline, and there's a lot of similarities with the human PAD. And there's 80% homology in some of the molecules that PAD citrulinates in the mouth. So the hypothesis is, does this organism cause citrullination in the oral cavity, and then through processes like molecular mimicry, there's spillover to endogenous autoantigens that become involved. So this led us and a lot of people to look at this in more detail. So we went to two different First Nations communities in Norway House and St. Treat's Point, and we used this epidemiologic instrument called periodontitis screening and recording. I wasn't familiar with that, but the dental hygienist we had working with us said this is the best thing to use. And if you got a 0, you got really nice gums, and if it's 4, it's bad. And you can see here that 80% in both populations, both communities, had 3 and 4s for their scores in using this epidemiologic instrument. We show that there was an association between immune responses to the organism, Porphyromonas gingivalis, and having the RA autoantibody, anti-citrulline protein antibody, both in the relatives who are at risk and were autoantibody positive, and in the RA patients. So this wasn't a phenomenon that we're just seeing in RA. This is individuals who are at risk for RA. There was this association, suggesting that it may be an environmental trigger that's in play early on before the disease actually develops. And we couldn't show this with rheumatoid factor, which is the other autoantibody we see in RA that's been well studied. Okay, so I'm going to talk more about the 2 middle stages later on, but I want to get to the final stage, which is the development of seropositive RA. What does that look like in First Nations people? Okay, so this is work that was published, in various phases, but that's looking at First Nations in Manitoba and compared to non-First Nations. And the rates of RA are at least 2 to 3 times higher in First Nations. This is all administrative data, and I think you have great databases here. We have great databases in Manitoba, so it's a good way to do this type of study. And interestingly, the incidence, there was also a big difference, the estimated incidence, but it looks like the incidence might be declining as compared to the prevalence, which over the years seems to be going up. The age of onset of RA in First Nations is 10 years young. Okay, typical RA in non-First Nations is kind of 50s, late 40s, early 50s. The average age of onset in First Nations is late 30s. And obviously with more women than men in both populations being affected. The disease is predominantly seropositive in this population, and there's an interesting phenomenon of having anti-nuclear antibodies in conjunction with the RA-associated autoantibodies. So, and we don't see this as much in other populations, but you can see here there's a huge majority of Korean Ojibwe First Nations people that are ANA positive, along with being positive for anti-CCP and rheumatoid factor. We actually published an interesting paper showing that ANA, even though it's prevalent in the whole population, it doesn't mature and lead to RA the way that the RA autoantibodies do. So they evolve, the titers go up, and we'll talk a bit more about the maturation of the autoimmunity. The ANA stays in the background and doesn't change. So it's an interesting phenomenon. Anybody want to pursue that? And we see this in quite. Now we do see a few clinical overlaps. The occasional person that has called rufus, or this kind of overlap between RA and lupus, but for the most part, the ANAs are just there. The pattern of joint involvement, looking at Caucasians versus First Nations, you get a lot of large joint involvement, which are disabling joints, knees, elbows, shoulders, and we have an instrument called in rheumatology called the Health Assessment Questionnaire, which is based on, can you lift a cup, can you get in and out of a car, and so on. That translates into disability. You can see here the three cohorts. One is an early cohort, one's kind of a mid cohort, 5 to 15 years. Excuse me, one is an advanced cohort. And as time progresses, First Nations people accrue more and more disability related to many factors, but particularly to this large joint involvement that we observe. Now, I mentioned this in the environmental risk factors. The age of menarche is significantly lower in First Nations people. And you can see here on your left in blue, the age of first birth is completely different in First Nations compared to non-First Nations. And you can see here the number of pregnancies comparing First Nations and non-First Nations. What's the importance of this is that there's no question there's a link between the postpartum period and the development of rheumatoid arthritis. And there's a mistake here that the one on the far right should be less than 1 year. So if you use greater than 15 years as your reference for the development of first RA, and you compare within the first year postpartum is a very high period of risk for developing rheumatoid arthritis. So those parity characteristics that I showed you in the population probably play quite an important role in predisposing, particularly, obviously, First Nations women to developing early rheumatoid arthritis. Now, I'm not going to show a great deal about the outcomes, except this figure, which unfortunately, this is a Mac PC thing. It didn't come out the way I wanted, but it basically shows that First Nations people with incident RA die 20 years younger than non-First Nations people. Multiple factors, comorbidities, cardiovascular diabetes, all of that, but that speaks for itself. Okay, so in view of this perfect storm of risk factors, severe disease, unfavorable outcomes, how can we work with First Nations people to reduce the burden of RA through prediction prevention strategies? And this leads me to the next part of the talk about some guiding principles in how you conduct studies in First Nations communities. And I'm not going to be prescriptive here because most of this is out of the Tri-Council policy statements. And though any of you who do work in this area will be familiar with that document, you have to do the course. And so Chapter 9 is devoted specifically to doing health research in First Nations people. And these are the principles. I'll go through them quickly. You got to show up. You got to go to the community. You can't use Zoom. That's just the way it is. With the community, you develop the nature and the extent of the community engagement that's discussed, negotiated. Takes time to build reciprocal, trusting relationships. You have to respect Indigenous people's knowledge systems in planning, decision-making, all stages of the project. And you have to respect local community customs, ensuring a balance in the relationships between the researchers and the participants, because you can see a scenario where there's a kind of an inequity there as you engage with First Nations people in these communities. Another Mac PC thing. So that's supposed to say, and a very important point is that in addition to individual consent, you have to have community consent. We're used to doing, health research. You go out and you sign this, you explain it to people. But in addition to that, in communities, you have to have community consent, which basically means a research agreement. You have to have a research agreement with each jurisdiction. And that becomes onerous if you're working with 3, 4, 5 different communities, each with their own system, tribal council and chief and band council and so on. But you have to have one because you can use templates and say, let's develop a research agreement based on this template, but each one has to be unique to that community. Those of you who work in this area, the principles of ownership, control, access, and possession, and they really guide you in terms of what you do with samples, what you do with data, and culturally appropriate ways of destroying samples and returning the community and so on. There's some very important principles are laid out, and those are very much part of these agreements that you develop. We have, I'm sure you do here, an excellent Office of Research Services, which is well-versed in developing these agreements. You need legal review, both on the part of the community and the university. And the university undertakes these agreements on your behalf as a researcher. Okay, so that's an important link. And then getting an advisory body made up of elders, health leaders, patients, research personnel is a typical requirement, and then amendments as needed through the history of that. Okay, so this is what we did through generous funding from CIHR, uninterrupted for many, many years. We assembled a cohort of at-risk people by recruiting the RA patients. We didn't follow them, they were followed standard of care, but we asked them to bring their relatives in, and we would enroll them in the study, a longitudinal study. We also had a bunch of controls who didn't have a family history, and we'll come back to that a little bit later. And then assembled this at-risk cohort that we followed longitudinally for now probably 20, 25 years. And some people developed RA under our watch. A lot of people didn't develop RA. Most of the people didn't develop RA. So this was we worked in the urban community in Winnipeg, and then these two communities in particular, Norway House and St. Teresa Point. And I've got some interesting pictures of flights in Alabama, which I'm not going to show you, but they're actually Perimeter Airlines, more reliable than WestJet. Anyway, they get us there and they bring us back. And and our collaborator Liz Ferrucci in Alaska worked with the Tlingit population there, and the late Janet Markland in Saskatchewan was involved in this study as well. Okay, so about 5 years ago, we were able to put together a story that we published of 18 progressors versus 356 non-progressors. How did they differ? How were they similar? So the first thing you note is that the progressors were younger. The average age was 30 compared to 37 in non-progressors at enrollment. And there's a controversy in the RA literature that obesity is associated as a risk factor for RA. What you see here is the BMI, which is known to be high in this population, was almost significantly lower in the progressors versus non-progressors. So we certainly couldn't support obesity being a risk factor for RA, at least in our study. And then type 2 diabetes, highly prevalent also, 20%, as you see in the non-progressors. Not a single person who progressed had type 2 diabetes. Is this just an idiosyncrasy of our data set? Maybe, but we certainly couldn't support the hypothesis. Okay, so when you work that out to cases of inflammatory arthritis per 1,000 person years of follow-up, you see here 4 autoantibody groups. The double negative at baseline, the rheumatoid factor only positive, the anti-CCP only positive, and then the double positive. And you can see here that, as you would expect, the double positives is almost 10% that will develop RA versus 4 in 1,000 person years for the double negative at baseline. And the latency, if you have a double positive, is 3 years as compared to 5 years. So this is important because if you're going to do prevention studies, you can't wait 5 years. At least I can't. I've got too much gray hair to wait 5 years to get the outcome. So powering your study on 5 years of follow-up is very difficult to do. And we'll come back to this concept of finding surrogate endpoints to tell you you're actually doing something if you do prevention. Now, the other thing that was quite surprising to us was our statistician told us about this model, multi-state model, where if you are in a certain autoantibody state today, you're CCP positive, ACPA positive, what's the likelihood that in a year, 2 years, 5 years, you're going to be in that state or another state? Okay? And I'm not going to spend a lot of time on this, but I just bring to your attention that after 5 years, if you have a double positive at baseline, 40% will have gone on to develop RA, but almost 40% will have reverted to seronegative. This was a big surprise because we thought, hey, this is a one-way street. You get these autoantibodies, not so. So there is something to the autoantibodies being matured that in some people that develops this autoimmunity becoming pathogenic as opposed to it just going away. Now, so the top part of this figure, as you would expect, if you have autoantibodies, your risk of developing RA is very high. But we looked at symptoms of these individuals who, at baseline, we talked to them, asked them simple questions. Do you have hand pain? Do you have stiffness? Do you have swelling subjective? And you can see in the bottom panel there was no difference between the progressors and the non-progressors in terms of symptoms. Everybody said they had pain in their hands, they had stiffness, and so on. Not everybody, but a high proportion. So we had a medical student, a very good medical student. I talked about her last night, Dana Weens, who went through this and looked at disability, this disability questionnaire, this, can you lift the glass, get out of the car, and so on. With that, you can easily discriminate the progressors from the non-progressors based on functional scores. And the ACPA positive individuals had higher disability scores than the ACPA negative. And those disability scores went up in parallel with the autoantibodies until disease developed. So asking functional questions is probably a better way of getting at subjective symptomatology than just saying you have pain in your hands, you have stiffness and so on. Okay, so let's spend a little bit of time talking about what excites me, and hopefully it excites at least some of you in the room, which is prevention of an autoimmune disease. And that's really has become the holy grail of autoimmune disease outcome. You know, if you can prevent it before it even starts, we will have really accomplished something. I mean, the cardiovascular world, they're all familiar with this, in the diabetes world and stuff, but the autoimmunity world is just starting to wrestle with this. Risk models that we see in cardiovascular disease are just being developed now for the development developing disease like RA. So there's two ways you can get people into your studies. And the first way is the one I've just described to you. You do population health, bring in the first-degree relatives, enroll them, health fairs, and so on. And the second way is a symptom-driven approach, which is primary care physicians refer them to you and say, this patient's got symptoms, they got pain and stiffness, and they have autoantibodies. I think they've got RA, or they've almost got RA. So the importance of this is that the population-driven approaches get you people on the left side of the figure, of that preclinical disease figure. And this is, and to get that population health part of it, we've developed screening tools which are scalable. For years, we went up to the communities, you know, expensive flights, research nurses, 4 or 5 people going up, put together, you know, a study day or two. We've developed this dry blood spot technology, and the people who do infectious disease, the serology people that we work with folks at the National Microbiology Lab, they've been doing this for years. But if you can adapt that methodology to detecting autoantibodies. So go in there and you put a lens, you get a drop of blood, put it in an envelope, put it in the mail, and they send it to us. We extract the protein from the dry blood spot, and we test it for the autoantibody. Scalable, easy to do, and this is the health fair we had in a hockey rink there at Norway House. Huge turnout. You try to time your visits with things like that, because that you really makes it worth your while to do this. And we did this to pilot the methodology, and we showed very nice correlation between what you see on the dry blood spot and if you test in serum for the same autoimmune. Now, the symptom-driven approaches identify people much closer to the onset of RA, imminent RA, and we talked a lot about this last night in terms of engagement of the synovium and so on. The importance of this is if you use a population-based approach, the individuals you recruit into your study, at 5 years, less than 20% will have developed RA. If you use the symptom-based approach, at 5 years, 70% will have developed RA, and at 2 years, 50%. So you're much closer to the onset of this autoimmune disease simply on the basis of how you recruited your people into the study. So if you recruit your people from offices in downtown Edmonton, you're going to get a certain population compared to if you have a health fair in a First Nations community and you do this testing. And it's important to keep that in mind as you put together, try to put together prevention strategies, what kind of patient or pre-patient population. Now, we've developed a concept, and many others, around this stage of maturation of the autoimmunity to what we call from the autoimmunity, the gene-environment interactions that I described, to maturation of pathogenic autoimmunity that actually targets the joints and causes this disease to start. And I like to think about it as the point of no return. Once you've matured that autoimmunity, it's very tough to turn back. And I'll show you evidence of that. So how do you define that? this is a complicated figure. I'm not going to spend a lot of time on it. Simplified for you a little bit. The list of names there on the right side is a bunch of endogenous autoantigens, citrullonated fibrinogen, vimentin, all of the things that we've detected as endogenous autoantigens in RA. Bill Robinson at Stanford has this array, and it says, looks at the reactivity of each individual serum to multiple autoantigens. Each block is a person, and each column in each block is a visit. So let's hone in on one of them. This individual at baseline, and then 4 visits, and then at RA onset. What you're seeing is at baseline, there's not a whole lot of red. At RA onset, there's a whole lot of red. So there's this epitope spreading of the autoantibody response to involve multiple endogenous autoantigens. And that's the immune system doing its usual thing. It's, you know, when you're talking about a microorganism, it wants to get the best immune response. So targets multiple epitopes. When this happens in autoimmunity, it has devastating consequences. And if you actually develop a score, an ACPA score, you can see that at baseline versus RA onset, in almost everybody that developed disease, this went up. And there was a question raised last night about the level of ACPA. What does that tell us? And high levels of ACPA generally mean lots of epitope spreading. So if you see a patient, they come in and their level is, for argument's sake, is 50, and then 6 months or a year later, their level is 300. Okay, that's telling you not only is the level of a single specificity going up, that the actual autoimmune response has expanded to involve multiple autoantigens. And now the other thing that will tell us about the maturation of the pathogenic autoimmunity is the ACPA autoantibody itself, the IgG molecule. And you're familiar with the glycosylation that happens in the Fc portion, because that determines how this antibody interacts with Fc receptors. And there's inhibitory receptors and activating receptors, and the sialic acid content of this N-glycosylation with the asparagine in position 297. All the antibodies have that, and depending on the composition of the carbohydrate, there's different reactivities with different Fc receptors. Now, we became interested in glycosylation in the antigen binding part of the IgG. And there is no asparagine to accommodate that N-glycosylation in germline. Okay, so in order for the B cell to accommodate carbohydrate in this region, you have to have somatic hypermutation. Okay, the B cell has to hypermutate, and in order to do that, you have to have T cell help. So this is a very interesting concept that was developed in Leiden, Uli Scherer, Rene Tuss, and you can see here that you get a B cell that gets T cell help, it matures, it somatically hypermutates, and develops a sequence in the FAB region, in the variable region that accommodates carbohydrate. And so why is that? What does that do? What survival advantage is there to getting a carbohydrate there? And the Dutch are busy trying to figure that out. You know, the reality is that there's some kind of a survival advantage for that B cell to get carbohydrate in that region, but it becomes a very good biomarker because it tells us it's the footprint of T cell help. Why is that important? You can see here the RA patients. These are all RA patients from our cohort, but the RA patients from the Netherlands look exactly the same. High levels of glycosylation, but you look at the first degree relatives, they span a whole bunch of, some of them have high levels, some of them have low levels. To make a long story short, these are kind of the spaghetti plots. People who transition to develop RA have higher levels of glycosylation than those who don't transition. And you can see this is unique to the ACPA because all the other immunoglobulin that flow through, there was no differences in the glycosylation of the FAB. Why is this an important biomarker? Because if you have heavily glycosylated ACPA, your risk of developing RA is a hazard ratio of 6 times that of somebody who's got low levels of glycosylation. So it becomes another important biomarker as we think about the maturation of the autoimmune response. We talked about the epitope spreading. Here's yet another way we can say that this individual has actually matured their autoimmunity to become pathogenic. And this was multiple cohorts around the world. This was put together in a recent paper. After you develop the disease, there is this heavily glycosylated ACPA throughout the course of the disease. If you look at people who are in remission with RA and you look at their ACPA, they still got heavily glycosylated. It doesn't go away. And it's just telling us that the autoimmune response that we're trying to turn off is very difficult to turn off. Okay, so Liam O'Neill and I, apart from the autoantibody positivity, we did a broad proteomic analysis of 1,300 different proteins using something called a SomaLogic platform, and came up with a 23 biomarker panel that could very accurately, in the years preceding the onset of RA, differentiate the progressors from the non-progressors. And I want to point your attention to the figure here. We looked at 2 time points, one close to the onset when they were months away from developing RA, and one more remote when they were 2-3 years away. And you can see that these proteomic changes were there years before the disease developed. And if you look at those 23 different proteins, everything pointed us to innate immunity. Toll-like receptors, activation of innate immunity that parallels the maturation of the adaptive immunity with the autoantibodies. Okay, I'm not going to spend time on this for the sake of the individuals who had to talk last night, but we talked a lot about this imminent RA, point of no return. This point, when the synovium becomes engaged, is almost certainly beyond the point of no return. So individuals develop these symptoms. We call it in rheumatology clinically suspect arthralgia, and it involves things like recent onset symptoms in the MCPs, long duration of morning stiffness, and so on, but no joint swelling, because that's what we need to make a diagnosis of RA, is a swollen joint. These individuals have what we call arthralgia. They're stiff, they're sore, but their joints aren't swollen. And again, a lot of this is Dutch studies that have looked at synovitis, tenosynovitis in particular. The flexor tendons, the extensor tendons show evidence of preclinical inflammation before the disease has actually become classified. So what do we want to do? We want to take individuals before they've developed disease, and in comparison to the line in red, we want to treat them for a period of time and then stop treatment. Otherwise, if we keep them on treatment, we haven't accomplished that much, right? Because we do really well right now, keeping people on treatment, keep them in remission. The holy grail of prevention is to do something for a limited period of time and then have an enduring effect. So true prevention is the green line. You treat, you stop, and people stay in this low level of inflammation. There are 2 other outcomes. One is you can treat and people will get better, and then as you stop treatment, they go back toward this is the orange line, go back towards the red line, or which was recently shown in one of the studies, is you can make the disease less severe at onset. You didn't prevent the onset, but you made milder diseases much easier to treat. I'm going to go through this very quickly, but this is all the work that has been done to date to try to prevent RA. And this is almost all done in individuals with that imminent RA stage with clinically suspect arthralgia. Early study more than 10 years ago, give them a couple of shots of steroid, did nothing. Maybe lowered the autoantibodies a little bit, basically nothing. The Prairie study, again in the Netherlands, give them a shot of rituximab. Makes sense, deplete B cells. If you deplete B cells, you may be able to turn it off before it starts. Delayed it by a year. That's it. Everybody got disease. The Treat Earlier study was using methotrexate, our anchor drug. Give it for a year, subcutaneously, good doses, and see what happens. And what they showed is the MRI inflammation was turned off and stayed turned off. But in effect, the disease restarted 12 months later. Even though the MRI wasn't showing it, the disability scores were favorable and persisted, but the disease was not prevented. So this suggests that treatment with methotrexate for a year, when stopping it, maybe generated milder disease. It's easier to treat. Two studies just published back-to-back in Lancet a couple of months ago using abatacept, which is a T-cell co-stimulation inhibitor, and we use it regularly in treating RA. Very well suited to what we're trying to achieve, which is to prevent the maturation of the autoantibody response, those interactions between T and B cells that I described. Very promising work. The curves didn't quite meet the control and the drug-treated individuals. So, but still, most of the individuals that were treated got their disease delayed, but didn't get it prevented. And then the very disappointing results at the bottom there, the hydroxychloroquine's NIH-funded study at a University of Colorado, they treated with Plaquenil for a year, and that's a lot of rheumatologists would do that. Nothing. They had to stop it out of futility when they were halfway through the recruitment. So much as we'd like to embrace this, Plaquenil, the mild drug that's well suited for this, it didn't work. Why didn't these work? Our hypothesis is that it's beyond the point of no return. You can delay, you may make milder disease, but you can't prevent disease with this. So what do the individuals actually want us to do? And this is a nice summary in a review article, quite recent here. So individuals with symptoms are willing to take preventative medication, are more likely to accept that than individuals without symptoms. You'd expect. The more appetite for oral versus injectable medications. It depends on the risk you tell the individual that they have. If you tell them they got a 7% risk of developing RA, nobody's going to want to do anything. If you tell them they got a 40% risk, they're much more likely to want to do something. What you tell them about the potential for the intervention to reduce their risk. If you tell them that they're going to go from 60 to 40%, I don't know. But if you tell them they're going, start at 60% and they're going to go down to 20% or 25%, there's much more of an appetite for it. And then we had some focus groups in our communities, study communities, and there was a lot of, pardon the pun, appetite for dietary interventions, natural products, this kind of thing. And I'm sure you'd see that in a lot of the patients that you would see. Well, is there something I can do that's natural other than taking a pill? So, which brings me to the VITAL study. And I'll just very quickly go through this. 26,000 Americans got supplemented, NIH-funded study for 5 years with omega-3 or vitamin D or both in an attempt to prevent cardiovascular disease, cancer. 5-6 years ago, back-to-back New England Journal of Medicine papers, nothing. No cardiovascular prevented, no cancer prevented. But Karen Kostenbader and her colleagues did a secondary analysis of that, and the people who got both together, there was a demonstrable reduction in the incidence of autoimmune diseases, particularly RA. So this got us quite interested. And we added, we thought that if we added a third natural product, curcumin, the active ingredient, the curcumin was in the turmeric, and there's a nice review of that, showing you a meta-analysis showing you that it actually does work in RA, and it's great at reducing autoantibody levels. Rheumatoid factor, we don't have much data about ACPA. So if we use these three together, maybe we can, this is well suited to what we're trying to achieve. So we had an animal model, collagen-induced arthritis. You immunize the mice with bovine collagen. You wait 2 to 3 weeks, and the mice develop inflammatory arthritis. If you supplement them with a combination of these, you almost completely prevent the onset of the arthritis in the mice. And you can see here, clinical scores, histological scores, the levels of anti-collagen antibodies, and the cytokines profile, all of them, you did a very good job in actually reducing the risk and the manifestations of inflammatory arthritis. So this is what we're trying to do now, is put together the study of a randomized study of the three ingredients together, and then with a crossover design that the clinical trialists tell us that's the most efficient trial design for this. Then we realize we don't know what the primary endpoint is. We're not going to wait 5 years. I told you, you have to wait 5 years if you supplement the people and then see what happens. We are in desperate need of a primary endpoint that's based on a combination of biomarkers, something that will tell us we're actually doing something. So we're just embarking on an open label study in the ACPA positive individuals by dry blood spot that I showed you, dry blood spot positive, verify that with a serum test, enroll them in supplements for 3 months, and look and see what immunologically we've been able to do with. So in conclusion, RA has unique biological, phenotypic, and epidemiologic characteristics in First Nations people. Developing RA prevention strategies requires enduring partnerships with First Nations communities based on trust and mutual benefit. It's been difficult to prevent RA in individuals at the imminent stage, possibly because it's past the point of no return immunologically. And upstream population-based approaches need careful consideration of risk-to-benefit ratio, since we are going to overtreat a whole bunch of people. So you better have safe interventions if you want to get early enough to actually prevent the autoimmunity from maturing. With that, I will leave you with a long list of collaborators in multiple places: the Arthritis Center at the University of Manitoba, the lab that I work in, the Manitoba Center for Proteome Systems Biology, the Ongamazin Institute of Health and Healing, particularly Elder Margaret LaValle, who is now well into her 80s, elder in residence at the University of Manitoba. Wonderful, you know, the intellect of an academic and the heart of a grandmother. She's just awesome. And she's been working with us for 15 years on this study. I can't thank her enough. Department of Immunology, I already talked about the oral health piece, the Center for Healthcare Innovation, the clinical trialists, Liz Ferrucci in Alaska, our colleagues in Leiden, the various other, and particularly the chiefs and band councils of the community. So thank you very much.
You stay right here.
Okay.
I think we have, well, 1 minute, maybe for a couple quick questions. Walter?
Wonderful talk, very thought-provoking. I wish we had 15 minutes. But RA has undergone a lot of evolution. We see less severe disease. We don't see nodular disease very much. We hardly see very much synovitis when patients present. And our proportion of seronegatives is going up tremendously. And the relationship of serological predictors, anti-CCP and RF, with outcomes has diminished as we've used interventional therapies like biologics. So the question I have for you is, what are we seeing in the native groups and those at risk of rheumatoid arthritis? Are we seeing the same trends emerging? And we're still seeing these same relationships between the prognostic factors and outcomes.
It's a great question. So the first part of your question about the decreasing severity, is this related to smoking? Smoking, the rates are going down dramatically in the population at large. And smoking is not only a risk factor for developing the disease, but for developing severe disease. With lots of extra, I mean, we used to see these all the time, heavy smokers, nodules everywhere, nodules in their lungs and so on. We don't see that very much anymore. Number one, is it related to smoking? Two, early detection, early arthritis clinics, the rheumatologists here see people, their friend down the hall calls them up and I said, somebody I suspect has RA. We get at them early, we got lots of tools. So have we nipped it in the bud early enough that those complications simply aren't seen anymore? The toolkit that we've got, as you alluded to, is very full compared to certainly when you and I, Walter, started practicing. When I still remember the gold days, gold shots, and so all of these are probably variables that go into the secular decline in severity. Is this happening in First Nations? The nature of the study we've done really can't answer that well. We followed a certain number of people. We need to do some good epidemiology to see, particularly using administrative data, to try to answer your question, harmonizing that with clinical data, and I'm sure there's lots of people that can do that. We're still seeing lots of severe disease in this population. We're still seeing lots of smoking in the population. We're still seeing people that are undiagnosed for a long time. And one of the things that I feel particularly good about is in doing this study, we've actually been able to get people treatment very, very early, as opposed to this delay that we see in these communities where you get somebody who comes in with 5 years, 10 years of disease and with lots of nodules and all the things that are possible. So no simple answer.
We are at 9 o'clock. If those in the crowd have more questions, I'm sure Hani will stick around for a few minutes. Thank you again so much.
Yeah.